Okay, this is again Meldita, and this is a continuation of our kidney transplant. Here at my YouTube channel, Meldita's Info Corner. My Facebook is joelregacho@yahoo.ca. Okay, so the operation of the patient is finished. So operation is finished. And as I said, the duration of the surgery is 4 to 5 hours. Cases vary. Difficult case and complicated will be longer. And pretty straightforward or uncomplicated or uneventful will be shorter. And the operation of the patient will be comprising, the closure. The skin closure will be done with staples. So obese patients, they have longer incision with staples. Medium-built patients will be probably shorter incision with staples. Okay, so the patient is ready to come out of the operating room and proceed to PACU. Okay, so the patient will be handled by the PACU nurses. Okay, in the olden time, they used to call PACU, actually recovery room is the name of PACU, but that has been changed to PACU or post-anesthetic care unit. So the patient will be handled by the PACU RNs. Continuous monitoring will be done with their assessment, vital signs, and more. And seeing, they are monitoring the patient with regards to his anesthesia recovery. They're watching for post-op complications like bleeding and more. They will be checking the progress of urine output. This is a kidney transplant. But one transplant doctor says that sometimes the kidney donor is still asleep. And probably the patient will still be on dialysis for months maybe until the kidney donor will wake up. But that's probably an exceptional case. The PACU RNs will give anti-rejection medications and PRN medications for pain because that will be very painful once the patient starts waking up and more. Once the patient is stable in PACU, the patient will be transferred back to transplant unit. And in here, there are some things to be observed. So there will be continuous communication between the patients and family and the staff. The family will be taking, active roles or participation in the patient's recovery. Cytotoxic precaution, there will be a sign outside the door. I will discuss more cytotoxic precaution with my next video. Continuous monitoring and with assessment, vital signs, and more. Frequent check or monitoring of urine output by the patient. The transplant doctor says that we have to hydrate the kidneys. We're not going to starve the kidneys by drinking 6 to 8 glasses per day. That's why it's very important that there's a family at bedside. The medications of the patients, like giving anti-rejections medications, regular medications if agreed by the doctor. If not, then that could wait. And PRN medications for pain because that will affect the mobility of the patient. There will be blood works drawn with blood levels of tacrolimus. If the tacrolimus level is low, then they will increase the dose of the tacrolimus. If the tacrol levels will be high, then they will lower the dose of the tacrolimus. And we'll know that the anti-rejection medications of the patients, there are 3. These are the anti-rejection medications. We have the tacrolimus, the mycophenolate, and the prednisone. So with the blood work levels, they are concerned more of the tacrolimus. And again, this medication, I will be discussing them with my next video. Okay. The diet of the patient initially will be clear fluids, 2 progressive diet, 2 diet as tolerated. Be sure that the patient is observing this diet. And once eating more, like a liquid to soft diet, be sure that they're eating well. Okay, the family has to be there at the bedside. Ambulation. So since it will be very painful for the patient, as I mentioned, the obese people, they have longer incision with staples. The medium-built have shorter incisions with staples. So it will be very painful on their parts. So for any activity to be done, be sure that the patient will have a narcotic analgesic. So from lying down for hours, we can encourage sitting up at the edge of the bed and then soon take steps to the bedside chair and few steps to the door and to the hallway. So these narcotic analgesics are good only for probably, hours. And then after that, we'll start introducing non-narcotic analgesic like Tylenol until the discharge. So probably day 2 or day 3, we're done with the narcotic analgesic. We will be more on Tylenol, PRNs. Okay. So the earlier the ambulation, the earlier the recovery, and the lesser the complication. Daily rounds. The daily rounds require the presence of the family members so that they will be given the update of the patient and if there are concerns. Okay, that's why I'm saying that we need an active participation with the care of the patient. We are not going to rely on the staff. We take our part. This is all our collaborative effort. The family, the staff, and the other, and other disciplines. So we need that for the early recovery of the patient. But the patient has to take the initiative to do more for his early recovery. So family and patient, we need hydration, we need good nutrition, and we need, early ambulation. That will speed up the discharge of the patient, and we will, make it with the pathway. So usually the pathway or uneventful stay in the hospital takes like probably 5 days. So if the operation is done Sunday night, for example, the discharge will be after 5 days, and that will be Friday. Okay? So again, the anti-rejection medications, we have tacrolimus, we have mycophenolate, the prednisone. Okay? And with my next video, I'll be talking about cytotoxic precautions, anti-rejection medications, and discharge instructions. Okay? Thank you so much.